The following podcast is part of a certified educational activity titled Making Progress Across the Continuum of HER2-Positive Breast Cancer in the Context of an Expanding Treatment Landscape and Persisting Disparities, featuring Dr. Sarah Hurvitz from University of California, Los Angeles in Los Angeles, California, Dr. William J. Gradishar from Northwestern University Feinberg School of Medicine in Chicago, Illinois, and Dr. Sarah M. Tolaney from Dana-Farber Cancer Institute and Harvard Medical School in Boston, Massachusetts. Access the entire activity and complete the post-test at peerview.com/SAA860. Downloadable slides and practice aids are also available.
Hello there. Welcome to our program, Making Progress in Early and Advanced HER2-Positive Breast Cancer, leveraging HER2-targeted therapies and modern care principles to improve clinical outcomes and health equity. I'd like to welcome my colleagues, Sarah Tolaney and Bill Gradishar. I'm Dr. Sarah Hurvitz from the Johnson Comprehensive Cancer Center at UCLA. Dr. Tolaney is from the Susan F. Smith Center for Women's Cancers at the Dana-Farber Cancer Institute. And Dr. Gradishar is from the Robert H. Lurie Comprehensive Cancer Center at Northwestern University. Welcome to my colleagues this evening. I'm looking forward to our discussion. So today we're going to be having candid conversations and clinical consults in HER2-positive breast cancer. Dr. Gradishar, Dr. Tolaney, and I will be going through some cases and discussing different treatment issues and how we make treatment decisions. But before we begin with our presentations, let's briefly focus on disparities in breast cancer clinical care and research. It is really important that we recognize disparities and the need to provide equitable care to all patients with breast cancer. In fact, ASCO highlighted this year as an area that requires special attention. The Tiger Lily Foundation has partnered with us in this program to bring in the patient perspective and shine a light on disparities in breast cancer care and breast cancer research. Mayma Carmo is the founder and CEO of Tiger Lily Foundation. She is a 15-year survivor of triple-negative breast cancer. Her journey with breast cancer motivated her to create an organization that would educate, empower, advocate, and support other women affected by breast cancer. Let's hear from her now.
Hi, I'm Mayma Carmo, a 15-year breast cancer warrior. When I heard the words, "you have breast cancer," my life changed, and I had to think about how to save my life, but then also how to ensure other women had access to the right kind of treatments and time, and how to help them be their best advocates as well. So while in treatment, laying in bed, going through chemotherapy, I began a nonprofit that's grown called the Tiger Lily Foundation that helps to educate women of color, women of all colors actually, but those who are facing cancer at a higher risk, who are women who are dying of the most of breast cancer, young women, and brown and black women. So our mission is to educate, advocate for, empower, and support women going through breast cancer, and to ensure that we work to end disparities of age, stage, and color in our lifetime.
As mentioned, recognizing disparities and the needs to provide equitable care in breast cancer is critically important. Some examples and facts include Black women have lower rates of diagnosis of breast cancer than white women, but are diagnosed at a younger age, at later stages, and with more aggressive subtypes, and have the highest death rates. Let's hear from Jamil, a patient with metastatic breast cancer who encountered many barriers after her diagnosis at a young age.
Black women die of breast cancer at a 40% higher rate than white women. The narrative was, oh, well, it's personal responsibility. They just don't have enough money. Then it was access to healthcare as to the reasons why, we have these disparities. However, what was interesting, though, is that in those areas where all things are equal as far as treatment, insurance, and those things are not a factor, that they still had disparities in their survival outcomes.
Racial and ethnic minorities are more likely to experience delays in therapy, less likely to obtain adequate treatment, and are also significantly underrepresented in clinical trials. Let's hear from Lori, a physician and a patient with metastatic breast cancer who advocates for more diversity in clinical trial participation.
What we know about clinical trials is that not enough Black women are in clinical trials. Less than 10% participate in clinical trials. We know that when we look at the statistics, it's about being asked, it's about being considered. I know that with this diagnosis that it is an opportunity for me to give a voice, to give a platform to women that look like me that may not have that opportunity.
We must acknowledge and address disparities across the entire breast cancer care continuum, especially in an environment of increasing care complexity and expanding treatment options. Let's hear again from Maima Carmo, founder of Tiger Lily Foundation.
So what I want to leave you all with today is this, that as a provider, you are your patient's best advocate. The healthcare system is very complex, and right now we're dealing with multiple challenges with COVID and cancer. But the thing is that you went to medical school for a reason and took an oath to be that person who's there for your patient. So each patient you meet is an individual person with their own challenges in their life and their cancer care. And your job is to make sure they have access to the high quality, equitable care throughout their cancer journey. And so I'm calling on you today to ensure that everyone you meet, every patient you meet, you have the power to change that person's life and work with them in a way that's actionable to ensure they have quality care throughout their cancer continuum.
All right, now we're going to turn to our program where Drs. Talani, Gradishar, and myself will be discussing a few cancer cases and how we approach the treatment. First, let's turn to neoadjuvant and adjuvant therapy, and let's consider a case. A 42-year-old Black woman with a history of hypertension and obesity presents to her primary doctor for enlargement of her left breast, has never had a screening mammogram. She is a single mother of 2 children, ages 10 and 14, who works as a medical assistant and plays piano for her church choir. On presentation, mammogram does reveal a 6-centimeter mass with regional level 1 axillary lymphadenopathy by ultrasound. Biopsy reveals an ERPR negative, HER2 positive breast cancer. Genetic testing is negative. Her performance status is good. She has completed childbearing and does not wish to preserve fertility. And she does help to care for her mother. She does have friends at church who provide her support. So I'd like to turn to Dr. Gradishar now and ask you a few questions about how you would manage this particular patient's situation. Can you take us through how you would discuss neoadjuvant versus adjuvant therapy decision-making for this patient? What are the pros and cons of this approach that you are recommending? And what do you ultimately recommend, giving therapy prior to surgery or after surgery? Can you tell us a little bit about what we know about long-term outcomes based on response to therapy prior to surgery and how you may use the results at surgery to guide adjuvant treatment?
Thanks, Sarah. And this is a great case that really illustrates a lot of the issues that we confront or should confront when we're making treatment decisions. And what I'll do is go through the data, but I think the things we should highlight about this patient is her comorbidities, that she's a single parent with a lot of things on her plate, not only responsibilities for her children, but her mother, and that she has outside interests that are important to her. So all of those things have to be integrated into a decision about how to optimally treat this patient with HER2 positive disease. So if we think about the current approach for the treatment of HER2 positive breast cancer, in the neoadjuvant setting, we can sort of segregate patients into 2 groups in a very broad sense. One is patients who have smaller node-negative tumors, and that could be defined as tumors that appear to have a size less than 2 centimeters, they would be appropriate to consider surgery as a first step. And again, in these patients, depending on what is actually found at the time of surgery, may dictate the optimal adjuvant therapy, whether it should be a trastuzumab, taxane regimen, or TDM1, or if they have a more volume of disease, where they would be more appropriate for a treatment regimen that includes dual HER2 targeting with trastuzumab and pertuzumab, and even consideration for additional therapy after a year of dual HER2 targeted therapy. Whereas in patients who start out with bigger tumors who are node positive, these are patients who are most likely going to be recommending preoperative therapy for. And what we're really trying to do is achieve a PCR, because we do know in such patients that the overall outcome in the long term is optimal. They're going to do better. And if they receive optimal preoperative therapy, and despite that, they still have some residual disease, there are maneuvers that we now know can still enhance their overall outcome, including switching the HER2-directed therapy to TDM1, and then possibly in select patients, even considering a TKI such as neratinib later.
Yeah, that's really important, the points that you raised about how we use the response at the time of surgery to guide the therapy that we give after surgery. It's only very recently that we had data to support the fact that switching therapy is an approach that will change a patient's outcome. Sarah, I'm really curious, if you see a patient before the patient has gone to a surgeon. For example, this patient comes to you with a 6-centimeter tumor and regional lymphadenopathy, and you pretty much know that neoadjuvant therapy is what you're going to recommend, assuming the patient is on board and interested in pursuing this. Do you have them consult with the surgeon prior to initiating therapy? Are there reasons why you would or would not do that? Not just the breast surgeon, but also the plastic surgeon, or would you wait until the patient had started therapy?
Yeah, I think that's a really good question. And as Bill pointed out, we are really moving towards preoperative therapy. In fact, for the large proportion of our patients, again, people who have, tumors over 2 centimeters or have nodal involvement. And so it is, becoming more and more critical to think about these things. I'll say our group has moved towards multidisciplinary appointments so that any new patient who comes in with a new invasive cancer does see not only medical oncology, but also surgical oncology. And so then as a team, we can make this decision about whether or not they're going to go to surgery first or go to upfront chemo. And getting the surgeon's input upfront, at least in my mind, has been very critical. We need to make sure that obviously the clip's in the right place, the nodes have been evaluated upfront. If they're going to be a mastectomy patient, that they do get that consult with plastics. That doesn't necessarily have to happen prior to initiating pre-op chemo, but at least it gives them that time to see them even while they're getting their preoperative therapy. So those discussions in my mind are quite critical to have early before starting therapy, at least predominantly with the surgeon, and then making those referrals that they can do during treatment.
Yeah, and along those lines, probably a radiation oncologist isn't a bad idea to see the patient, given the fact that nodal status may impact radiation therapy recommendations post-mastectomy if the patient is pursuing that approach. Are your patients also seeing radiation oncology around the time of initiating neoadjuvant therapy?
Yeah, that's an interesting question. Our group has actually gone back and forth on this. And I think in part, honestly, just from a practical purpose, that we don't have enough radiation oncologists to really see all of our new invasive cancer diagnoses up front. And so that has been a challenge. And so we have been trying to integrate radiation oncology up front when it's felt that there's a necessary question to get them involved with. Because I think, to your point, it is an important thing that can be helpful to have discussions up front for.
Excellent. Thank you for those insights. So our particular patient has decided to pursue a neoadjuvant regimen, which brings up or begs a number of questions, Bill, back to you. in terms of how you choose which neoadjuvant regimen you're going to recommend. What are the toxicity and efficacy factors that you prioritize most in a patient like this? Is it her impact on work, as a mother, medical risk factors, for example? And then how do you approach the anthracycline versus non-anthracycline decision? What are the data supporting one versus the other approach? When do you use pertuzumab and what are the risks associated with that? And the impact of choice of therapy on quality of life in terms of hair loss and neuropathy. This is a woman who really enjoys playing piano in her church choir. And she's also taking care of her children. So how do all these factors weigh in to your recommendations and decision-making with her? And finally, when she asks you, and most patients do ask, what do you gauge her chances of achieving a path CR are?
So again, those are all good questions, and I think there are things that we have to think about in relation to each patient. It was interesting at ASCO, I had the privilege of discussing some of these issues, but in the metastatic disease setting. But the important point was that if you ask physicians and patients the same questions, what are important to you, you get different answers. The patients are as interested in efficacy and toxicity as the doctors, but they also have a broader list of things that are critically important to them. How is it going to affect their day-to-day life, their interactions with other people, their ability to do things that are important to them? So it's not that physicians discount those things, but I think we have to be more acutely aware of the importance of them when we're talking to patients about treatments. So when we think about some of the questions you posed, we have a large data set now from numerous trials over many years that help inform us. And if you look at the issue of whether anthracycline-based therapy is necessary, a trial that you and your colleagues on the West Coast are very familiar with, which is the BCIRG-006 trial, looked at ACT or ACT with trastuzumab or a non-anthracycline regimen, TCH. And I think as we recognize with long-term follow-up of this data, that the outcomes are very much the same, but importantly, the TCH regimen, understandably in the absence of an anthracycline, has less cardiac toxicity and some of the other consequences we worry about, like secondary leukemias. So again, you're not losing efficacy as demonstrated here, even in the higher risk group of patients who have node-positive disease. If you look at the blue and tan lines, they're basically very similar to one another, suggesting that if you partner trastuzumab with chemotherapy, you're going to improve over the absence of trastuzumab, and there's no real big advantage to using an anthracycline. And that whole issue was driven home even more definitively with the TRAIN-2 regimen and report that is shown here. And this was an effort to look at a preoperative approach that either had an anthracycline or did not, and then looking at the PCR rate between the two regimens. And it pretty definitively, if you look at the bottom right-hand side of the slide, see that there's essentially absolute equivalence between the two regimens with respect to whether you're going to get a higher PCR with one or the other. They're superimposable. And most importantly, we like to look at not just PCR, but what's the long-term consequence? Are the clinical endpoints affected by PCR? And here we see that whether you had an anthracycline in terms of effect or no anthracycline, event-free survival was superimposable between the treatment arms. And furthermore, if you go through the different categories of patients, those on the left who might be viewed as having less risk of recurrence, all the way up to node positive or even greater nodal burden, there's really no difference between the two treatment groups, suggesting that you are not disadvantaging a patient by avoiding an anthracycline. So my view, and the data I think supported, is that there are similar long-term outcomes with taxane-based therapy compared to anthracyclines, even the highest risk patients. Furthermore, you're not affecting any greater toxicity. In fact, there's less cardiac toxicity and less of the hematologic malignancies. So my own view is that currently we don't have much of a justification for the continued use of anthracyclines in this setting. If we go on to what could be viewed as optimal neoadjuvant or preoperative therapy, we have a number of trials that informed us a number of years ago. And what constitutes these different regimens are a little bit different between them. They clearly had both pertuzumab and trastuzumab. The chemotherapy was a little bit different. But if you cut to the chase and sort of look at the fraction of patients who were achieving a PCR, you can see that with dual HER2 targeting, you're in the 50 to 60% range with some of these early trials, which was pretty remarkable, demonstrating that dual HER2 targeting was rendering many of these patients without disease in the breast or the nodes. Now, as we go forward and start to look at whether we can substitute some of the constituents of the preoperative therapy, we can look to the Christine trial, which was a comparison of TCHP versus TDM1 and pertuzumab. And I guess the issue that was being addressed there in some respects is whether you could achieve the same thing with perhaps less with less toxicity related to chemotherapy in the form of TDM1 rather than using TCHP. And if you look at the patients on the right who had a PCR, the patients receiving TCHP still had numerically a little bit higher rate of PCR than the patients getting TDM1 and pertuzumab. But if you look at the invasive disease-free survival, there was absolutely no difference between the two. And at 3 years, it was roughly around 93%. So no space between the two. But I would submit that today, for the vast majority of patients, we're still using TCHP, although you could justify the alternative regimen based on these data. Now, one of the interesting things that I think we all recognize is that when we see HER2 positive patients and administer preoperative therapy, not everyone achieves a PCR. And what might be the underlying reason for that? Otto Metzger and his colleagues looked at this question in a phase 2 trial where they did a very rigorous evaluation of the pathology. Patients were confirmed to have HER2 positive disease. They were treated with TDM1 and pertuzumab, and then they went on to surgery. And when they analyzed the pathology specimens carefully, they did note that there was heterogeneity with respect to expression of HER2 in many of the samples. And if you look at the data from that trial, I think it's very informative. The pathologic PCR rate on the left across the board was just short of 50%. As we've seen in other trials, if it's a HER2 positive estrogen receptor negative population, they tend to have a higher PCR rate as compared to hormone receptor positive. But what's really striking is if you look at the fraction of tumors that had heterogeneity within them, in other words, some areas of the tumor might have been less HER2 positive or negative, and others HER2 3+ as an example, the heterogeneity was related to basically nobody getting a PCR. Whereas if there was non-heterogeneity in the tumor, the PCR rate was much higher. And this may, of course, explain some of the observations we've seen on our individual practices with patients. Now, what to do about patients who have less significant disease in the sense that they don't have large nodal burden or a huge tumor? And this was addressed by Sarah Tolaney on the program with us tonight in the APT trial. This was a large trial of about 400 patients, HER2 positive and either ER positive or ER negative with node negative disease, tumors less than 3 centimeters, who received the combination of paclitaxel weekly and trastuzumab for 12 weeks and then went on to complete a year of trastuzumab alone, so a full year of therapy. We have very mature data from this trial at this point. Now it's 7 years. And you can see the striking outcome of these patients. There were very few recurrences. And although over time, there was a little bit of diminution in the disease-free survival, 3, 5, and 7, even out at 7 years, again, you're seeing the vast majority of patients without any evidence of recurrence. Recurrence-free interval is maintained over the long haul. So this was a demonstration that not everybody needs the full Monty, so to speak, of aggressive chemotherapy, dual HER2 targeting, we can tease out patients with lower burden of disease who will do very well with a less intense regimen. And to that end, there's efforts that are looking at whether we can even further enhance that effect. The ATTEMPT trial addressed whether or not TDM1, rather than a paclitaxel trastuzumab regimen, could be used with equal effect. And again, these were patients with early stage disease, HER2 positive, stage 1 disease. They were node negative or N1 Mike, and they either received TDM1 every 3 weeks or they received the regimen you previously heard about, paclitaxel trastuzumab for 12 weeks followed by trastuzumab. And if we look at the data that's available, the follow-up is not quite as mature as the long-term follow-up that you saw with trastuzumab and paclitaxel, but you're seeing at 3 years a 97% disease-free survival. So again, very clear that this is equally effective. We would expect perhaps that there may be some drop in this with time, but nonetheless, a very effective regimen. And if you look at the toxicity, you are decreasing the fraction of patients who are experiencing neurotoxicity, but there was a higher discontinuation rate with TDM1. So again, there is efficacy, but there are some nuances with respect to the side effect profile. There are other trials that are ongoing. One is to look at the ATTEMPT-2 trial, which is a similar population of patients. Again, the overall theme here is, can we de-escalate therapy, making toxicity less, but not compromising on efficacy? So this is a trial in which TDM1 is given for 6 cycles, followed by trastuzumab to complete a year. And importantly, it's subcutaneous trastuzumab, which again may make lifestyle issues and getting patients out of the office that much easier. And that is being compared to the TH regimen, but in this case, subcutaneous trastuzumab after the paclitaxel is complete. And then the ADEPT trial, which is a single-arm phase 2 trial, is depicted here. And this is, again, early stage disease, stage 1, patients who are ER positive, who will receive subcutaneous HP, a newer preparation that's currently available, plus endocrine therapy of the investigator's choice. And this will be followed out. We don't have data from either of these trials, but these are eagerly awaited. So I would say that what we have is an evolution of therapy that not only optimizes the outcome for patients with higher volume, more worrisome disease, but we have de-escalating strategies that give equal efficacy with less toxicity for those with a lower burden of disease.
That was a great summary, Bill. Thank you so much. You really did review all of the data in a very sweeping manner, but let me put you on the spot. What are you going to recommend for her in the neoadjuvant setting?
Well, this is a patient, again, if she had clearly bulkier disease, our go-to thing would be TCHP. We still sit by that. If it was somebody that we thought could go to surgery first because of small tumor, less than 2 centimeters, et cetera, then we might be more inclined to use the TH regimen. But our standard preoperative therapy for a bigger tumor, somebody who's got nodes, would be TCHP. And again, it's a discussion because you not only have to talk about what you might expect with PCR rates, but also the toxicities which are relevant to this woman who has a lot of responsibilities.
Absolutely. Well said. I just want to ask Dr. Tolaney a quick question about cardiac risk factors. Outside of LVEF measurement, which we should do at baseline and throughout therapy with HER2 targeted treatment, although it's never been proven that this helps us catch it early enough or manage it well. That said, we all do that. Are you engaging with cardio-oncologists, cardiologists, doing any strategies in terms of medications to mitigate risk of cardiomyopathy in patients being treated either with or without anthracyclines and HER2 targeted therapies?
Yeah, no, I think that's a really important question. And, as you were alluding to, rates of cardiac toxicity are much higher when given with anthracycline sequentially with trastuzumab compared to a non-anthracycline regimen. We see rates of cardiac toxicity more in the 4 to 5% range relative to like 0.5 to 1% range with non-anthracycline therapy. So very different risk. So, at this time, I also am monitoring all our patients, whether they're getting anthracycline or not. That being said, I think to your point, there is a lot of controversy out there, particularly when giving a non-anthracycline regimen. What is the utility to this sequential cardiac monitoring? Our group had looked at this in the APT trial, which had a 0.5% rate of cardiac toxicity with TH, and looked to see if there were predictors of what was going to lead to someone having a drop in their EF in a non-anthracycline-based treatment. And what we found was that baseline borderline ejection fraction was certainly one risk. And then having 2 or more cardiac risk factors would put you at risk. And so I think one proposal and something that I think needs to be studied is if you could look at these patients who sort of have 2 or more cardiac risk factors, have a baseline borderline EF, and see, what their rate of cardiac toxicity is compared to those who don't meet those criteria. That may help us tease out if you really do need to do that sequential monitoring. But at this time, it is standard. And I think to your other point about cardioprotective meds, there actually was a really nice abstract at ASCO this year looking at this, whether or not utilizing ACE inhibition or beta blockade would be cardioprotective and help prevent these drops in ejection fraction that we see. And I think, again, the challenge is that the numbers are so small because cardiac risk, thankfully, is low, where we do see, again, more of it with anthracycline-based therapy. And there was some suggestion that ACE inhibition could help prevent some of these drops in ejection fraction. But at this time, I think my take is that it's not really ready for prime time because we don't see enough cardiac toxicity, I think, to warrant cardioprotective meds in all comers. That being said, maybe in select patients with significant cardiac risk, it is worth thinking about. And I think engaging, a cardiologist, in our case, we're lucky to have a couple cardio-oncologists that we work with, is what I do when I have a patient with cardiac risk up front.
Excellent, excellent. All right, let's turn back to the case. And our patient does receive neoadjuvant TCHP. She has a near complete clinical response. And at the time of surgery, she's had a great response, but she still has 2 millimeters of residual disease in the breast and a 5 millimeter lymph node. She had 8 lymph nodes removed. Remember, she was clinically node positive at the time of diagnosis. So she did have an axillary dissection. Only one had a little bit of cancer left in. Biomarkers were repeated. ER and PR remained negative. HER2 remained positive. So, Dr. Gradishar, what treatment do you recommend for this patient in the adjuvant setting who's had neoadjuvant TCHP and has a very, very good response, but not a complete response? And a couple of questions come up because I'm predicting you might say TDM1. So assuming you say TDM1 in the adjuvant setting, how do you time that with radiation? How do you time that with reconstruction? What are the toxicities we need to consider, again, in this woman who's got a very busy, full life? And a couple of other questions that have actually come up from the audience is, if she had had a path CR, would you have recommended pertuzumab? And would you recommend neratinib? Why or why not? If it were ER positive, would that have changed your recommendation regarding neratinib? And talk a little bit about the toxicity. So we've got a bunch of loaded questions here now in the adjuvant setting. Can you take us through some of the data to help us answer these?
Sure, and let me just try to succinctly comment on a couple of things. And that is, first, with respect to TDM1 and the radiation question. I mean, the trials were designed that radiation could have been given concurrently, but quite frankly, we don't have huge amounts of data on that. I think most of us feel that it's probably okay to do that, but it's still, I think we need more data to be absolutely confident. This is another bunch of questions that really beg the issue of you got to talk to the patient, make sure they understand what's going on. And you're correct, I would recommend TDM1. She did have residual disease, and we have a justification for doing that based on some of the data from trials I'll show you in a moment. However, she did have a PCR. Similarly, you might be inclined to say, well, we don't need the pertuzumab anymore, but the long-term benefit globally was when you got a year of pertuzumab. But could you say that is true for the ER positive patients, which we'll come to in a moment? So there's a number of different issues in here. And then the final one with neratinib, and thinking about the patient that we've described in this case, you would have to have a very invested patient and a big concern because you're going to buy some side effects potentially and a much longer duration of therapy. So these are all very complicated questions that are germane to the patient that's sitting in front of you that may not be as important to the next patient you see. So they're very complicated. So let's go to some of the adjuvant data. I think we have justification for dual HER2 targeting, not only based on the Cleopatra study, which Sarah will talk about when she discusses metastatic disease, but the neoadjuvant data showing that you got high PCR rates. So this was the rationale for putting together the affinity trial with dual HER2 targeting, outlined here, a big trial, chemotherapy plus trastuzumab, pertuzumab, or chemotherapy plus trastuzumab. And as folks know who are listening, if you look at the long-term follow-up that's available now, median follow-up of 74 months, at first blush, the lines look pretty close, but as you get out farther, there is a delta favoring pertuzumab of about 3%. So when you do use dual HER2 targeting and follow the patients long enough, you do start to see a clinically meaningful difference emerge. And importantly, if you look at the subsets of patients, if you look at the entire population and look at the delta between those that got pertuzumab and those that did not, it already pointed out about 3%. Hormone receptor positive, at first we were thinking that this was a population that there was no demonstrable benefit, but with longer follow-up, we're seeing essentially an equivalent added benefit between those with hormone receptor positive disease and hormone receptor negative disease. Where you really see more of a striking effect is in the node positive or higher risk patients, and not much of a benefit in those that are node negative. So again, hormone receptor positive or negative and node positive, clearly pertuzumab is adding something. At present, we don't have sufficient follow-up to see a survival difference. Now, what about adding neratinib? So a patient's gone through 12 months of trastuzumab or trastuzumab-pertuzumab therapy. What's the justification for more therapy? Well, the Extenet study was such a trial that looked at the issue of switching from a trastuzumab-based regimen to neratinib. And this was a trial that I think many people are familiar with, where they were randomized 1-to-1 to either get neratinib or no further therapy. And these were patients who had prior adjuvant trastuzumab. But importantly, it's not the TDM1 residual disease setting. It's not the affinity setting where patients have had trastuzumab and pertuzumab. But nonetheless, if you look at the data from this trial, at 5 years, there's a delta of about 2.5% favoring neratinib. And if you look at the overall survival at 8 years, again, the lines are looking pretty superimposable. But if you tease out patients who might have been higher risk, and that was defined as patients that did not achieve a PCR post-neoadjuvant therapy. So think of the patients who were in this trial who were deemed high enough risk to get preoperative therapy and yet did not achieve a PCR and were hormone receptor positive and less than a year from the completion of trastuzumab. At 5 years, the IDFS is more striking. It's about 7.4%. And if you look at the 8-year estimate with respect to survival, it's even more striking at about 9%. So though this isn't a perfect trial to compare to contemporary pertuzumab or residual disease TDM1, there are hints that there are select patients who clearly might benefit from this strategy. And if you look at the association between the treatment duration and overall survival, you can see that, again, there is a delta that seems to favor, in a modest way, but about 2 to 3%, neratinib in this population of patients. Now, one of the issues that I think everybody is familiar with as it relates to neratinib is the early concerns when this drug was being developed of the risk of developing significant diarrhea, in fact, a high rate of grade 3 diarrhea. And there have been a number of strategies that have been developed over the years to try and mitigate that. And I know Sarah will mention some of those in her discussion as well. But I think what we've come to appreciate is that if you slowly escalate the dose of neratinib week by week, not starting out at the desired dose right from the get-go, the fraction of patients who are going to experience significant diarrhea is significantly reduced. And if you combine that strategy with other maneuvers like starting loperamide right from the get-go, and there have been other studies looking at loperamide, colestipol, and even steroids added in, that the risk of developing significant grade 3 toxicity is markedly reduced. So although at the outset of its use, this sort of got a bad rap, I think there are strategies now where you can mitigate those side effects and patients are able to stay on the therapy for an extended period of time.
Excellent review of the data. Again, let me put you a little bit in the hot seat here. For this particular patient with hormone receptor negative breast cancer that started out as pretty high risk, TCHP, almost a complete response, but residual disease, getting TDM1, neratinib going to be discussed or not?
Well, I guess I would discuss it, but I wouldn't be pushing it. And the reason I would say that is unless the patient was highly motivated to do absolutely everything that she could, understanding the potential side effects, I wouldn't be overly enthusiastic. And it's not because neratinib's this or that. It's simply because within the Extenet study, a population who got TDM1 was not studied. And nor were there patients who really were receiving preoperative pertuzumab to any great degree. So I think it wouldn't be something that I would, strong arm the patient into, I guess is what I would say.
Okay, sounds good. I do concur with you, and the fact that her tumor was hormone receptor negative, I think, adds even more data that perhaps she wouldn't be one to benefit as much. But along those lines, as to who might benefit and what benefits might be seen, we do know that CNS recurrences are not common in the adjuvant setting, thankfully, but women with high risk HER2 positive breast cancer remain at risk for developing a recurrence in the central nervous system. They do occur. There were some data, Sarah, that were presented briefly related to Extenet, relating to CNS recurrences. Sarah and I had been talking about this a little earlier, and I'd like to ask you, Bill, if you can go through a couple of slides relating to the CNS recurrences from Extenet and whether or not neratinib is having an impact there.
Sure. So I think if you look at the cumulative incidence of brain mets as a first site of metastases in that higher risk patient population, a hormone receptor positive less than a year from trastuzumab, if you look at those who got neratinib versus those that got placebo, again, as you pointed out, Sarah, this isn't a huge number of patients that experience this, but there's a suggestion, again, that those getting neratinib had fewer of such events. And for those who did not get a PCR having received neoadjuvant therapy, you can see that if you didn't get neratinib, there was numerically clearly more patients who were developing brain metastases as the first site of metastases. If you look across other trials, again, the fraction of patients who experience brain metastases is not huge, but when it does happen, it's a very important and devastating finding. So if you look at the Alto, Affinity, and Catherine trials, again, with follow-up that isn't real long, you can see that, again, it's not real common, but you're not seeing a lot of discordance between the different treatment groups in terms of number of individuals or the fraction of patients who are experiencing brain metastases. So I think, as we already pointed out in the case that we discussed, and hopefully as the discussion evolved, that the patients who seemed to gain benefit from neratinib were those higher risk hormone receptor positive, HER2 positive patients, and particularly those who had received preoperative therapy with residual disease. And again, as I pointed out in my comments, it isn't a perfect way to look at this because, again, this was a population when the trial was done who weren't receiving post-neoadjuvant TDM1 if they had residual disease, and there was a much smaller fraction of patients who had actually gotten pertuzumab. And then again, although we have strategies that mitigate against some of the toxicities, this is a heavy lift for some patients who have gone through a year of therapy already and then talking to them about additional therapy. But I think, as pointed out, we do have strategies that help diminish the fraction of patients with significant diarrhea. So we've mentioned a couple of times the Catherine study, which is outlined here. And these were patients who had centrally confirmed HER2 positive disease, received neoadjuvant therapy, and at the time, and neoadjuvant HER2 targeted therapy. And at the time of surgery, were found to have residual disease. And in those patients, they were randomized to either continue trastuzumab or TDM1. And if you look at the results of that trial, it was very clear that the patients who received TDM1 had a better IDFS compared to those who continued on trastuzumab. And it should be pointed out that even in the patients, there was even a small fraction of patients who started out HER2 positive and then they were reanalyzed, they were HER2 negative. Even in those patients, TDM1 conferred a benefit. And there was no size or amount, volume of disease that identified a patient group where TDM1 did not potentially offer an advantage.
That was an outstanding review of the management in the early stage setting. Thank you so much for going through that. I do want to ask you, before we turn our sights to the advanced stage setting, if there are any ongoing studies in the neoadjuvant or adjuvant setting that you're particularly looking forward to seeing results from.
Well, I think the theme of many trials is de-escalating therapy. And I think we may find that some of the ongoing trials that we don't have data from yet, where we may be able to diminish the amount of chemotherapy we're using, particularly in those that have had preoperative therapy, are exciting. And many of the drugs that Sarah is going to talk about, based on data from the metastatic disease setting, are predictably working their way into the early stage setting. So we're starting to see trials that are exploring combinations that include tucatinib or TDM1 plus other drugs that are used strictly in the metastatic disease setting. So these may slowly change the way we think about things, and the algorithm may shift where these drugs are used earlier.
Yes, I agree. I think it's a really exciting time. And as you said, we may have a ripple effect if we start using a lot of these agents in the early line setting. Hopefully we'll be preventing recurrences, but for those who do recur, it's going to change sort of how we approach the disease in the metastatic setting. On that note, we will turn now to a discussion on HER2 targeted therapies in the metastatic setting. And Dr. Taleni is going to take us through some data that will help us address this particular case here. We have a 62-year-old Latina woman who presents to clinic for newly diagnosed metastatic breast cancer. She has no social support system. She lives alone with her dog. She's considering giving her dog away right now because she does not have the energy to take him for walks twice a day. She's very symptomatic from her disease. She's unemployed due to the pandemic. She was originally diagnosed with a 1.3 centimeter node negative invasive ERPR positive HER2 positive breast cancer 4 years ago. She had surgery and then she was lost to follow-up. She did not receive radiation or systemic therapy. There are a lot of social and economic factors that prevented her from seeking care after her local regional therapy. She developed abdominal fullness. She had some right upper quadrant pain and significant fatigue that led her to go to the emergency room, where imaging revealed a very enlarged liver of 18 centimeters with multiple solid metastases. The liver enzymes were mildly elevated, 3 times upper limits of normal, but the liver function was normal. A biopsy was conducted and demonstrated metastatic breast cancer, again, triple positive and high grade. So turning to you, Dr. Tolaney now, can you take us through how you would manage this particular patient? What treatment options would you consider in the frontline setting? Again, not just considering her triple positive liver metastases, but also her symptomatology and her social factors, which may really get in the way of her being able to partake in therapy and accept treatment. Also talk to me about what you would tell her in terms of overall survival. A lot of patients will ask this question when they're first diagnosed with advanced disease. And how might her socioeconomic circumstances affect her outcomes? What would you do to address these complicated issues that she is facing?
Well, thanks, Sarah. I think those are challenging questions because this is a difficult case with a patient who is symptomatic with quite a bit of visceral involvement, but again, is having some social and sounds like financial challenges at this time. So I think why don't we go through the data for how to approach first-line therapy for metastatic HER2 positive disease, talk about what I think the standard is, but then also talk about what an alternative may be and see what may make sense for this particular patient. So starting with the first line setting, such as our particular patient is in, really the data that leads us to think about taxane with trastuzumab and pertuzumab comes from the Cleopatra study. This trial randomized patients in the first line setting to receive taxane with trastuzumab or to receive taxane, trastuzumab, pertuzumab, and really remarkably showed a very impressive difference in progression-free survival. But I think even more importantly was a over 16-month difference in overall survival. So really an unprecedented improvement in survival outcomes from the addition of pertuzumab to first-line therapy. And so I think these are the data that really have led us to adopt THP as a standard in the first-line setting. I think the challenge, though, is that there certainly are some toxicities with this regimen. I will say personally, I tend to use paclitaxel with trastuzumab and pertuzumab in the first line setting. An alternative would be docetaxel, trastuzumab, pertuzumab, as was used in Cleopatra. But I think when you think about the patient that we're thinking about, this means that the patient's going to need to come into clinic on a regular basis, need routine monitoring of labs, have potential chemotherapy-related toxicities, and so is certainly a factor for this patient. And so I think one question that then comes to mind is there an alternative? Is there an alternative that potentially would be better tolerated and easier, from not needing to come into clinic quite as often? And this patient does have hormone receptor positive HER2 positive disease. So I think it begs the question in our mind, is endocrine therapy an option for this patient? And so really, are there alternative treatment approaches? We certainly know that there is crosstalk between ER and HER2, with the thought being that if you were able to hit both ER and HER2 simultaneously, that you could actually better inhibit proliferation of a cell. And so there have been several attempts to study this. Here are a couple of trials that have really compared looking at endocrine therapy alone to endocrine therapy with HER2-directed therapy. And what you see here is that adding a HER2-directed agent to endocrine treatment does add a little bit of benefit. So there's a couple-month improvement in terms of progression-free survival. So there is modest improvement, but I will say, I think this isn't a home run and certainly does not quite compare to what we're seeing with taxane and dual HER2-directed therapy. But that was with single agent HER2-directed therapy. And so what about using dual HER2-directed therapy? How would that work in combination with endocrine therapy? And we do have some data for this. One trial that explored this concept is a PERTAIN trial. This trial has a little bit of a complicated design because it did allow for induction chemotherapy, or patients could go straight on to endocrine therapy with HER2-directed therapy. So they were randomized to get an AI with trastuzumab or an AI with trastuzumab and pertuzumab. And this study did demonstrate that adding pertuzumab to the endocrine agent and trastuzumab did improve progression-free survival. And I think this is what has led many of us to add endocrine therapy to trastuzumab and pertuzumab, particularly after induction therapy with THP in a patient who has hormone receptor positive, HER2 positive disease. I think most of us, when we stop the taxane, will add on an endocrine agent to sort of improve that maintenance progression-free survival. This is just the updated final analysis from Pertain, again, demonstrating the improvement in progression-free survival, although not a significant improvement in overall survival. And Dr. Gradishar was very involved in this trial, the alternative study, which did also look at dual HER2-directed therapy, but in this case, it was using ATKI, lapatinib, with trastuzumab instead of dual antibody therapy. And here again, you can see that there was an improvement in progression-free survival with the dual HER2-directed therapy relative to single HER2-directed therapy. So I think, again, the theme here is that using dual HER2-directed therapy with endocrine therapy is better than using it with just trastuzumab alone. But we're not seeing survival benefit when we do this. And I think that's an important thing to think about when we're faced with this decision. So in thinking about choosing between chemotherapy and dual HER2-directed therapy or endocrine therapy and dual HER2-directed therapy in the upfront setting, particularly for this patient, certainly the endocrine-based treatment is going to be easier. It's going to have less toxicity for the patient. It will improve progression-free survival relative to endocrine therapy alone by adding that dual HER2 blockade, but it's not likely going to lead to a survival difference. Whereas we know that with chemotherapy and dual HER2-directed therapy, we are improving survival in addition to PFS, and that we do see bigger response rates. And so in a patient who has visceral involvement, such as this particular patient who had a liver pretty extensively involved with tumor, having right upper quadrant pain, experiencing abdominal fullness, this is someone I probably would try to initiate chemotherapy and really to get that early response in this patient and hopefully extend PFS and OS as well. But if I had a patient with less extensive disease, maybe bone-only disease, and someone who may not be a great candidate for chemotherapy, then I would think about endocrine therapy and dual HER2-directed therapy in that particular patient. But I think there are other strategies we can use to try and make a patient's treatment experience a bit easier. And one thing that I have started incorporating into my practice is use of subcutaneous trastuzumab and pertuzumab. So this is also known as Phesgo, but it's actually much quicker in clinic for patients to come in and get the subcutaneous formulation than it is to get two different IV drugs. So in essence, both antibodies are mixed into one. They get an injection. Usually we do it in the thigh. It's usually pushed over about 10 minutes at the beginning, so around 8 minutes, and we're able to inject it under the skin, and then patients are able to go home. And so instead of waiting on like 2 sequential 30-minute drips with observations in between, you're able to get in and out of the infusion center very quickly. And so this formulation has been studied in a randomized trial comparing it to the IV HP in a preoperative setting where we could really see that the PK of the drug was similar between IV and sub-Q formulation. And in fact, rates of PCR were really identical between the two regimens, suggesting efficacy is really the same with sub-Q and IV treatment. There's also some really interesting data looking at patient preferences. And I think the Francesca trial was pretty clever because it allowed patients to sequentially receive IV followed by sub-Q or sub-Q followed by IV. So each patient actually experienced treatment with both strategies, and then they were able to say which one they actually preferred. And here you can see that clearly the vast majority of patients actually prefer the subcutaneous formulation relative to IV. And I think this is what I see in my practice as well. And so I have started switching people over to sub-Q, and patients do love getting out of our infusion center much quicker. So there was actually some really interesting data that was presented at ASCO this year, really looking at this idea of a patient who comes in the first line setting with ER positive, HER2 positive disease, and really comparing chemo trastuzumab to endocrine therapy trastuzumab and looking at outcomes. So it's a very clever study, and I think one that we've always wanted data for, and really showing there's no difference in progression-free survival and overall survival. But I think it's really important to realize a couple things. One, this is a highly selected patient population, and they're not using dual HER2-directed therapy. So I think you have to be cautious in sort of taking away the message that, oh, it's the same. You can just give endocrine therapy and HER2-directed therapy, and the patients will experience the same PFS and OS. I don't think we can conclude that. I think we can say in select patients who have limited visceral involvement and with limited disease, that using endocrine therapy and HER2-directed therapy is a reasonable alternative. But again, I would not say that in the overall population. And I think we don't really know how this would have compared if dual HER2-directed therapy was used, because we certainly know that with chemo and dual HER2-directed therapy, outcomes are really quite impressive. And so, this wasn't that same control used for the comparison. But I think it is, again, a reasonable choice in select patients.
That was a great review, and you've made a compelling argument for sticking with the Cleopatra type regimen. I would point out that although Cleopatra didn't allow endocrine therapy to be added in during maintenance, I think most of us in our practice, after doing induction 4, 6, or 8 cycles of taxane, adding in with the HP endocrine therapy, and it'd be really interesting to see long-term outcomes from the subset of patients who have hormone receptor co-expression who get an HP plus endocrine therapy type of regimen after induction. I think Pertain addressed that a little bit, but I think you raised some really important points, and I couldn't agree with you more. I want to throw a little wrench in this. Of course, we got to make sure that Bill is still awake here. And if this patient, Bill, had no CNS symptoms, no headaches, no problems whatsoever that would indicate brain imaging is needed, would you still do brain imaging at this point? And if you did do brain imaging, let's say she comes to you and somebody had already done the brain imaging and it showed a metastasis, would this change your first line treatment recommendation?
So the answer to both is probably no. I mean, I think the answer to the first question is probably evolving. And the issue becomes, if you find something in an asymptomatic patient, are you going to do something different than perhaps if it's a little ditzel, maybe it's a gamma knife issue, and you can just, continue with what your plan was. And if you had imaging in hand that showed a metastases, Sarah's going to share some data looking at agents that have activity in the brain. Would that necessarily change what you're going to do? And I think probably more often than not, it wouldn't. So I'm not sure that I would be uniformly getting scans on everybody who walks in with HER2 metastatic disease. But I think, now that we have active agents that work in the brain, the frequency of doing those kind of tests, I would predict, is going to go up. But I haven't adopted that uniformly yet.
Excellent. Thank you. All right, let's now turn to back to our patient here. Our patient is connected with a local cancer support community. She gets some help with walking her dog and some support as well with going to and from appointments. And she agrees to initiate therapy with THP. After 2 cycles, she's symptomatically much better. She's able to walk her dog on her own. And after 4 cycles, has about a 70% reduction in her tumor burden. At 6 cycles, she's had a complete response. She's developing, however, moderate neuropathy and edema related to the taxane. So she, as per Cleopatra, drops the docetaxel and continues on maintenance HP. And as we were discussing standard of practice, she initiates an aromatase inhibitor to be given with the HP concurrently. She does well, but 20 months later, after that, she does have progression with new 1 centimeter metastasis in the liver, as well as new lung metastases. So, Dr. Tolaney, can you take us through the treatment options in the second line setting currently, as well as ones that are being evaluated in clinical trials? This is a very hot area of research right now. And maybe talk to us a little bit in the course of your presentation about whether or not you use brain imaging to help select the next line of therapy.
No, such timely questions. I think that with, as Bill alluded to, I think our answers to this are going to evolve a bit over time. But currently, in the second line setting, I think our standard right now is TDM1. This is really based on the Amelia data that suggested when TDM1 was compared to capecitabine lapatinib, that TDM1 was associated with both an improvement in progression-free and overall survival. So again, if someone progresses on TDM1, on THP, as this patient did, I usually will think about TDM1 as a next line treatment choice. Certainly one question that comes up a lot is, will antibody drug conjugates penetrate into the CNS and allow for CNS response? I think there was some thought initially that these are really big molecules. They may not get into the brain. Are we going to actually see activity in the CNS? And so there is some data about TDM1 that actually suggests that it does cause responses in the CNS, particularly in patients who do not have an intact blood-brain barrier. So someone who's already developed brain mets, and we are seeing responses in the CNS. And so this is the Camilla study, which had included a cohort of patients that actually had CNS involvement. And here you can see that within the subgroup of patients that had brain metastases, you do see really nice responses within the brain. And so I think this really supported the idea that TDM1 does penetrate into the CNS. It can lead to CNS response. Again, I think this is in people who already have brain metastases. And so what it's not telling us is, can TDM1 prevent brain metastases? That we haven't seen to date. Certainly, Bill had showed us the data with the Catherine studies showing no decrease in rates of CNS recurrence with post-preoperative TDM1. But agents that do penetrate into the CNS are tyrosine kinase inhibitors. And so there are several TKIs actually that target HER2 that we'll review. I think some of the older agents that targeted HER2 were agents that also hit other HER family members. So lapatinib, for example, hits both HER2 and HER1. And because of that, you do see EGFR-related toxicities such as rash and diarrhea. And so I think that was one of the challenges that we've seen with lapatinib, is some of the toxicity that does come with it. But we subsequently have seen development of tucatinib. And so this is a very clever tyrosine kinase inhibitor because it is really pretty specific for HER2 and really spares EGFR. And so that really allows it to not only hit HER2 hard, but not get a lot of the toxicity that we were seeing when we were giving drugs like lapatinib. So this agent does have less GI toxicity than, again, we saw with lapatinib. And we had seen initial data from some early phase 1 trials that not only showed that there was activity systemically from combinations with capecitabine, but also in the CNS. And so this really led to a very pivotal trial, the HER2 CLIMB study. So HER2 CLIMB, in my mind, was probably one of the most clever registration trials that we've seen recently, because it not only allowed for patients who had systemic progression, but also allowed for patients who could have had CNS progression. So this is really very atypical, not normally the way we've previously designed registration trials. Normally, patients with progressive CNS disease were excluded from registration trials. But I think we all realize that 50% of our patients with metastatic HER2 positive disease will develop brain mets in their lifetime. And this really is an area of unmet need, and we need to be studying how to treat brain metastases. And so this study, again, did include patients who could have had untreated brain mets, progressive brain mets, or just systemic disease. And what the study found was that when tucatinib was added to capecitabine and trastuzumab, it resulted in not only an improvement in progression-free survival, but importantly, an improvement in overall survival. And what I thought was really cool and unprecedented was that there was survival benefit even in patients with active brain metastases. So we have never seen randomized data with survival improvement in patients with active brain mets. And so this was huge in my mind, and really, I think, has shifted our practice patterns. And because again, you're seeing intracranial response, PFS benefit, and OS benefit in patients with active brain mets. And this was sort of an exploratory, intriguing analysis that looked at time to new brain lesions. And you can see that there is a delay to new brain lesions in the tucatinib arm, sort of planting the seed. Can tucatinib actually prevent new brain metastases? And so this will be studied actually in a post-preoperative trial, the Compass RD study, which is actually looking at patients who had residual disease after neoadjuvant therapy, who normally we would give TDM1 to, but the trial is looking to add tucatinib to TDM1. And I think we're really curious to see if we'll see fewer brain metastases as recurrences. So we did see some updated data also at ASCO with regards to the HER2 climb survival, I think really supporting what we've previously seen, that with longer follow-up, the survival benefit is continuing to hold up. And when we think about toxicity from tucatinib, I think what we saw in HER2 climb was overall a very low rate of discontinuation of therapy, which I think speaks to the fact that generally speaking, this is a well-tolerated regimen. We do see that tucatinib is associated with diarrhea. And in fact, obviously this is added to capecitabine, which in itself causes diarrhea. So it is adding to that. And it also worsened the hand-foot syndrome that we see with capecitabine. So that the rates of PPE were a little higher with the triplet combination than with doublet therapy. And sometimes one thing I think it's important to remember is you can see a bump in liver enzymes. And so I do see this not infrequently in patients where I'm giving tucatinib. And I think remember that can be associated with tucatinib, and holding and dose modifying the tucatinib really does improve that significantly. There was also an intriguing analysis that was presented at ASCO looking at the drug penetration of tucatinib into the CSF. So this was a trial that was specifically looking at the combination of capecitabine, tucatinib, trastuzumab in patients with leptomeningeal disease, and looked at CSF drug levels of tucatinib and compared it to plasma drug levels, really suggesting the same drug level, suggesting that the drug is getting into the CSF just as well as it is to the plasma. And I think this is really reassuring for our patients with brain metastases and potentially with leptomeningeal disease. HER2 climb did not include those patients with leptomeningeal disease, but this particular TBCRC study is exploring the combination in leptomeningeal patients. And so hopefully we'll get those data soon. But I think this bodes well, seeing that the drug levels are getting into the CSF. So while I think, we have established that capecitabine, tucatinib, and trastuzumab is a regimen that does have robust efficacy, both systemically and in the brain, there's also efforts to see how we could move tucatinib forward. So there is one trial that's looking at adding tucatinib to TDM1 in the second line setting. And then there's also this trial that's looking at adding tucatinib to trastuzumab deruxtecan, which I think is a clever idea, seeing if maybe we're going to see not only better efficacy systemically, but also if we see efficacy in the CNS. And so this will be, I think, important data for us to have. So we did allude to the fact that tucatinib is also being studied in the residual disease population and Compass RD as well. So if we look at our algorithm, again, we covered that THP should be our first line treatment based on Cleopatra, that TDM1 was a standard based on Amelia. But interestingly, the HER2 climb study, even though it required prior taxane, trastuzumab, pertuzumab, and TDM1, the FDA actually gave an indication in the second line and beyond setting. And I think this is actually quite important, particularly because now we're using agents like pertuzumab and TDM1 in the early disease setting. And so patients who relapse may have already seen those agents, and because patients can develop brain metastases within their course of disease, and being able to have access to the drug a little earlier, I think, is important. So I think it does circle back to, Sarah, your question. if we know that an agent like tucatinib has efficacy in the CNS, should we be screening people for CNS disease to know if we should be using tucatinib treatment? And I think it's an important question that I think, as Bill alluded to, we don't really have a great answer for. Certainly our current guidelines do not suggest screening asymptomatic patients. But when there's an agent that has survival benefit in patients with brain mets, it does make you wonder if you should know. And so there are trials that are ongoing trying to address this question, looking at, in a randomized way, looking at doing brain MRIs for screening, looking to see if it will prevent neurological symptoms by catching those lesions earlier and potentially having a survival impact. So hopefully we'll learn more about that.
Excellent. Outstanding overview of an increasingly complex area now. We have so many agents available to us. Dr. Gradishar, I wanted to ask you about how you help patients stay compliant with treatments that are orally delivered, especially when they have side effects. Are there things that you're doing in your clinic? Are there resources you're utilizing, including resources to improve communication with patients to help with treatment compliance and side effect management?
Yeah, I think it's an important question and an ongoing struggle. I think we've often in the past been fooled, whether we're talking about endocrine therapy or capecitabine, or whether in the current topic we're talking about oral HER2 therapies, that sometimes patients are not compliant or adherent. And it could be for a variety of reasons, from toxicity, both physical as well as financial. It's a broad range of explanations. So I think we have to constantly reiterate and emphasize that obviously taking your medications, you don't get the benefit unless you're taking them. But we need to know what the side effects are, because, for instance, with the HER2 Climb regimen, which Sarah just spoke about, there are ways of modifying the regimen without necessarily compromising the efficacy of it that could be more tolerable for an individual patient. So I think we have to have that ongoing communication. We do have pharmacists that are in our clinic that speak with the patient, and we have nursing that also, the patients may be getting other things IV or other medications. They have an opportunity to interact with other members of the healthcare team that reemphasize the need to stay compliant.
Thank you. All right, so let's move on now in the home stretch of our program, which has been really full of very rich information. Our patient does receive TDM1. She does very well. She has a partial response. She tolerates it pretty well, but does develop some neuropathy and transaminase elevation. And then 14 months later, she has progression in the lung and lymph nodes. And so in this home stretch, Dr. Tolaney, we're going to ask you to review the very complicated sorting out of how to best sequence the agents that we currently have in our armamentarium. I think we have, at my last count, 8 HER2 targeted therapies for metastatic breast cancer available in the United States. That number is lower in other countries, but how do you, assuming you have access to all these therapies, how do you sequence these agents? Are you using brain imaging? You addressed this a little bit earlier. What would you recommend for this patient in the third line setting? And beyond, how would you address sequencing for her?
Those are really easy questions. I'll do my best. I think, as you alluded to, we do have a ton of options, which is really nice to have. But I think it also makes it a little complicated when thinking about what's the appropriate option and in the right sequence. And so we alluded to the fact that we have these tyrosine kinase inhibitors. Another TKI that we have is neratinib. So neratinib is a little different than lapatinib and tucatinib because neratinib is a pan-HER2 tyrosine kinase inhibitor that's an irreversible inhibitor. And so Bill talked about the use of neratinib in the extended adjuvant setting, but it also turns out we have data for using neratinib in the metastatic setting. And this comes from the NALA study, which compared capecitabine with neratinib to capecitabine with lapatinib, really in a third line and beyond setting for metastatic HER2 positive disease, and showed that the capecitabine neratinib regimen resulted in a better progression-free survival than capecitabine lapatinib, although there was no statistically significant difference in overall survival between the two regimens. There was, however, a delay to need for CNS intervention that favored the neratinib arm, suggesting that neratinib may have better CNS activity and was preventing more brain lesions that required intervention. But I think, as we've talked about, one of the challenges with neratinib is the GI toxicity, and certainly this may be a little amplified when you add it to a drug like capecitabine, which in itself causes GI toxicity. NALA, as opposed to Exonet, did actually require antidiarrheal prophylaxis with loperamide, but despite the use of prophylactic loperamide, the rate of grade 3/4 diarrhea was about 24%. But I think, as Bill talked about earlier, we do have very good methods to mitigate diarrhea, whether it's cholesterol, loperamide, or budesonide loperamide, or the dose escalation strategy. I think those regimens actually work very well. In fact, I have patients who end up quite constipated when I've used things like the cholesterol loperamide regimen. So I think they work, again, very well to mitigate this. But I think we have to put it into perspective with the other choices that we have in the third line setting. And that includes a new antibody drug conjugate called trastuzumab deruxtecan, also known as TDXD or DS-8201. This ADC is sort of a very novel ADC because it takes an antibody targeting HER2, but links it via a cleavable linker to a very potent topoisomerase payload. And it does so with a very high drug to antibody ratio of about 8. So I think, just to put it into perspective, relative to TDM1, which has a drug to antibody ratio of around 3, again, you're delivering a ton of chemotherapy on this antibody. And it is a payload that is also membrane permeable, meaning that once that chemo gets into the cancer cell, it can diffuse through the cell membrane into the neighboring cancer cell and kill it. And so even if the neighbor is HER2 negative, it's still able to get into that cell and kill it via the bystander effect. And TDM1 is not able to function via bystander effect. And so I think this mechanism has really led to very impressive activity. So we've seen data from DESTINY-Breast01, which was a single-arm phase 2 trial looking at the efficacy of trastuzumab deruxtecan in patients who had progressed on prior TDM1. And in fact, this patient population was extremely pretreated with a median of 6 prior lines of therapy in the metastatic setting. And despite this, we saw this unbelievable waterfall plot with a response rate of 61%. And what I think is really very cool is that there are only these 4 patients up here that did not have tumor shrinkage, really a disease control rate of 97% in a patient population with 6 median prior lines of therapy. Again, this is really unprecedented. And we see progression-free survival of about 20 months. So not only is it a very high response rate, but it's very durable. And again, while this is a single-arm study, it is not randomized data. We're seeing at this time a survival that's, on the order of 2 years. And so really, again, it does seem like even in a late line population, we have extraordinary efficacy. Certainly, there are toxicities with TDXD that we also need to consider. So it is associated with some nausea, and I do find that my patients not only need some anti-nausea prophylaxis, but I also have them use Zofran periodically over the 3-week course in between doses. We do see that it can cause some fatigue, about a 40% rate of alopecia, so you do need to warn your patients about that. But I think the toxicity that many of us keep in the back of our minds is this potential risk of interstitial lung disease. And what we've seen now with updated data is about a 15% rate of ILD. And I think the thing that has concerned us is that there was about a 3% rate of death due to ILD with TDXD. And so I think that has been what has really drawn our attention, is most of it is low grade ILD, but there are these few cases where people have died from interstitial lung disease, which is what makes us anxious. If you look at timing to onset of ILD, you can see that almost all of it occurs within the first 12 months, that there are rare cases that occur outside that 12-month of exposure. And we are getting some suggestions of some potential risk factors for ILD due to TDXD. including being of Asian ancestry, being heavily pretreated. Those have panned out to be potential risk factors. And I think we're eagerly awaiting what the ILD rate will be in less pretreated patients. But it is a black box warning to remember this ILD risk. And I think particularly important, because this is really different than the way we manage ILD from other drugs, is the guidelines actually say to discontinue T-DXd with grade 2 ILD, meaning any symptoms with ILD, you stop the drug and you start steroids. Grade 1, you're supposed to hold the drug and you can consider steroids, but if you see those radiographic changes and they're not symptomatic, you hold the drug, you wait till the radiologic changes resolve, and then you can consider restarting. This is very different than the way, for example, we manage pneumonitis from immunotherapy, for example, where we'll treat through grade 1 ILD. This is, again, different, and you do need to keep this in mind. And again, these guidelines are quite conservative because of the prior deaths that have been seen with this drug. So while we talked about the fact that we have T-DXd as a robust third-line option, there is also a new approval that came not too long ago with an agent called margetuximab. In my mind, this is sort of like a fancy Herceptin. So it's a drug that was engineered to be a monoclonal antibody targeting HER2, but engineered in a way where it will increase affinity to the low affinity to low binding receptors. So for example, it's going to increase affinity to things like NK cells and allow for better stimulation of the immune system to cause ADCC against your HER2 positive cancer cells. And so this agent was studied really as a substitute for Herceptin, seeing if it would work better than Herceptin when given in combination with chemotherapy in a third line and beyond population. And this was in the SOPHIA study, which looked at chemo physician's choice with margetuximab or chemo with trastuzumab. And what we found was that there was a significant improvement in progression-free survival. Although it was a small improvement, it was a 1.1 month absolute difference in progression-free survival that was statistically significant. I think one thing that has, however, made us think a little bit more about margetuximab is an exploratory analysis that was done based on genotype. And so if you looked at patients, for example, who had the CD16A F allele, you can see that there is actually a robust benefit in this population with a larger difference in progression-free survival than we see, for example, in the V allele population, with a larger trend towards survival benefit. Whereas in the V allele population, we actually saw the opposite trend, where actually trastuzumab looked like it was performing better than the margetuximab, although I think we have to be quite cautious because that's about 15% of the population that has V allele, and there were small numbers with imbalances in the arm. But I think it has made us question that, is this a drug that would have more profound benefits in a genotype selected population, so those patients who may have CD16A/F allele. So I think more work needs to be done to sort that out, and there are ongoing studies that will help us there. But for now, this is an approved option in combination with chemo in a late line patient population. So I think, as Sarah alluded to, we have lots of choices in the third line and beyond, including T-DXd. But I think, capecitabine neratinib becomes a little complicated because now we have tucatinib, which has survival benefit and has activity in the CNS. And so I think most of us have switched to using tucatinib here, and typically we'll use T-DXd or the tucatinib regimen in a third line setting. And I think margetuximab could be considered later, more in a fifth line setting after someone's used tucatinib and T-DXd.
Thank you so much. I think we have about 4 minutes for a couple of audience questions. So I'll do a rapid fire and maybe get some quick answers from you each. These are questions that I don't think we've totally addressed in your very thorough didactic. So we have a question from somebody who is in Canada. They don't have tucatinib or T-DXd for metastatic breast cancer available there. They only have compassionate access to neratinib. So if you have a patient, I'll ask Sarah this question, with brain-only disease, would you use neratinib before TDM1 or would you flop it? How would you address that given limited resources?
I think it would depend a little bit on the extent of the brain metastases. So for example, it was one brain met that I could SRS. I might SRS that lesion and go on to TDM1. Whereas if it was someone who had progressive brain mets after radiation, or someone who had multiple brain lesions that might require whole brain radiation, then I would think about capecitabine neratinib. So actually that is part of the NCCN guidelines, given there is some data that has looked specifically in patients with progressive brain mets, looking at capecitabine neratinib with about a 50% volumetric CNS response. So I think it would be a reasonable choice in someone with progressive CNS disease.
Okay, great. Bill, would you use TDM1 at any point for metastatic disease if it had already been given post-neoadjuvant?
Well, I suppose if there was enough of a time interval between completion of TDM1 in that setting, meaning residual disease, the patient didn't necessarily progress on the drug, so I may revisit it later on. But I think, again, I would probably use some of the other drugs, TXD, tucatinib, before I return to TDM1.
Excellent. The next question, I'll take it, just to be fair. What's the survival for patients with HER2 positive metastatic breast cancer compared to hormone receptor positive HER2 negative? And actually, the French group presented their ESME real world registry data at ESMO last fall that I thought was fascinating, because they collected every patient diagnosed with metastatic breast cancer from 2008 to like 2017 and subtyped them and looked at survival as it evolved from year 2008 to 2009, et cetera, and showed that triple negative and hormone receptor positive HER2 negative had no improvement in overall survival. A patient diagnosed in 2008 with metastatic disease, diagnosed with one of those subtypes, had the same survival, median survival around 40 months for hormone receptor positive HER2 negative, in the same years later. So we're not seeing the impact, at least now, of the CDK4/6 inhibitors in that setting. In contrast, the survival for HER2 positive metastatic breast cancer went from somewhere around 38, 39 months at the beginning and is up around 50 months, like the data that you showed, Sarah, from Cleopatra. So it's the only subtype where we are seeing a benefit. It's now the best subtype based on real world data. Kind of fascinating. All right, I'll do two more questions, and I think we're going to have to close tonight. This has been outstanding. So I'll ask you, Sarah, I'm going to put you on the hot seat for a neoadjuvant question. Should T1C tumors have neoadjuvant chemo, even if it won't change their surgical outcome?
I'll be honest, I struggle with this. And I think the reason is that we know from APT that a true T1C and zero cancer has outstanding outcomes with pretty abbreviated therapy, right, with just single agent taxane and trastuzumab. But we know that really only holds in a T1C and zero patient. And so the thing that makes me a little anxious in the preoperative setting is I don't really know their pathologic nodal status, right? I can say, hey, they don't have clinically enlarged nodes, but I actually haven't done a sentinel node up front. And so that makes me a little anxious, because I would have given more than TH to someone with nodal involvement. And I would have given pertuzumab-based therapy to someone who had a node involved and more extensive chemo. And so I think, again, it's a little bit of a struggle for me, because I don't want to overtreat or undertreat someone. And so I usually will take that patient to surgery. On the flip side, I realize I've missed an opportunity to understand response to preoperative therapy and be able to escalate if they failed to do so. And so again, I feel a little bit mixed, but I tend to take most of my smaller T1C patients to surgery up front.
Okay, thank you. Very good. And the last question, Bill, is if HER2 negative, if a patient has received your standard neoadjuvant HER2 targeted therapy, let's say TCHP, and the residual disease is HER2 negative, do you still give TDM1?
We would. And again, the data we base that on is from Catherine, where there were, I think, 17 patients like this who had a change in the receptor status, or their HER2 status, I should say. And they seemed to benefit to the same degree as those that were HER2 positive. So I don't think, based on what we know today, there would be any reason to deviate from treating such patients with TDM1.
All right. Well, I just want to thank each of you. It's been a pleasure, as always, to work with you on this program. Thank you so much for your insights and your succinct yet thorough. I don't know if that's an oxymoron, but wonderful presentations loaded with important data.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/SAA860. This activity is supported by educational grants from Genentech, Puma Biotechnology Incorporated, and Seagen Incorporated, formerly Seattle Genetics Incorporated. This activity is jointly provided by Medical Learning Institute Incorporated and Tiger Lily Foundation. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.